Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board-certified allergist and immunologist and serve as a social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders in the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with a personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.AAAAI.org. Today's edition of our Conversations from the World of Allergy podcast series is targeted towards Academy members, but really anybody who's interested in learning more about perioperative anaphylaxis, which is a topic that we have not addressed before. And today's guest is Dr. Gerald Volcheck. Dr. Volcheck is a professor of medicine in the Division of Allergic Diseases at the Mayo Clinic in Rochester, Minnesota. Dr. Volcheck is a leading expert in the area of perioperative anaphylaxis and has contributed to dozens of peer-reviewed research studies, review articles, and international guidelines. He also led the efforts in creating the new educational course through the Academy titled Hidden in Plain Sight, a Comprehensive Approach to Perioperative Anaphylaxis, which we'll also be discussing today. Dr. Volcheck, thank you so much for taking time to join us, and welcome to the podcast.
Thank you very much. Really appreciate the opportunity to be with you today.
Now, I think this is going to be a fascinating conversation, and you really have somewhat of a niche area of expertise, even within our own specialty. What got you interested in perioperative anaphylaxis? Do you have some interesting origin story that you can share with us?
Well, to me, it's interesting. I hope it is to the listeners also. But it goes back to when I was an internal medicine resident at Mayo in my second year. And it was one of those brutally cold February months. And we got a consult on the weekend for a perioperative anaphylaxis. Uh, Something I knew nothing about going in. I just remember I lived 8 blocks from the hospital, and it was, like 0 degrees, and I'm trudging in thinking, "Gosh, what am I gonna do with this?" And, so I got up there, got on the floor, was talking with the service, about, what was going on, and, at the time, they were suspicious for latex allergy, something that was just coming to the fore, really, at that time. And they said, "Yeah, we got a tryptase level," which again, 1994 was an
Mm.
exotic, test. So I said, "Oh, that's great," and we're looking at all the medicines they received, but again, I knew very little. It forced me to go to the literature, and then we could not look it up on a computer. So was heading to the medical library, the Index Medicus, looking perioperative anaphylaxis and for some review articles. And even then, I noticed all of the data was really coming from Europe, particularly France. They were the leaders in this. And there was one like US study from 1990, but otherwise nothing. Again, all the European, UK, Australia, Denmark, that's where, all the studies seem to come. So it was a very quick learning experience for me, but it was something that really caught my interest. And in talking with the patient, she offered, really important insight. I was doing my allergy history, and she said, "Yeah, whenever I would have a pelvic exam, I would get very swollen in that area, and even blowing up balloons, my lips would swell up." And she said, "I guess you guys probably would have wanted to know that before surgery." And I'm thinking, yeah, there's a lot to be learned about this. So it was, again, an eye opener for me. Tryptase 2 was a new thing at the time, and I remember one of the attending saying, "Oh, tryptase levels, I see a case report coming out of this." And sure enough, and that was my first medical case report was this latex perioperative anaphylaxis incident.
Wow. Oh my gosh. I appreciate you sharing that. You gave me personal flashbacks of in medical school, also before, the internet was widely available. You'd spend 20 minutes trying to find the journal on the shelves and then it was gone, right?
Exactly.
So-
You're just always hoping, "Please be there."
oh my gosh. Well, I doubt that your entire practice consists of evaluating patients with suspected perioperative anaphylaxis. So what are some of your other clinical and research interests?
Yeah, because perioperative anaphylaxis, fortunately isn't real common. Here I'll see maybe 0 up to maybe 5 a month, at max. But my other and I feel like I probably should whisper this, but I do enjoy seeing, chronic urticaria and angioedema. We've been involved in, a few multi-center studies, with some, novel treatments that, hopefully will provide, you know, better options for some of these omalizumab, recalcitrant folks, but also just kind of getting to know them and walking them through the process. And even if our clinical outcomes aren't the greatest, just being able to work with those people has been, really rewarding for me and hopefully for them also. So that
Uh,
I would say would be the other area, but I enjoy the whole field.
that's great. I think it's always helpful for our guests to just offer some basic explanations at the beginning of our conversation. That way, sort of our listeners are oriented. So, can we just start by
Sure.
having you define what perioperative anaphylaxis is for us?
Yeah, I mean, generally speaking, it is anaphylaxis, but it's occurring in the perioperative or peri-procedural time frame. And this, really starts as soon as the anesthesia started and can be before the actual surgery or the actual procedure. One thing we've been trying to do in this realm is define it better, as you're pointing out, because people use different criteria for it, and that makes some of the study of it difficult. What we've really been encouraging everybody to do that are, reporting on these people with perioperative anaphylaxis is to use the Ring and Mesmer modified scale for it. It's, just a 4-grade scale where 1 is skin or mucosal signs only, 2 are moderate signs from several organ systems, like we would expect in anaphylaxis. 3 are life-threatening signs from 1 or more, organ systems, and then 4 is circulatory or respiratory arrest. And I think it's really important that, again, everybody's using kind of the same criteria for grading, because I do think there's different mechanisms involved in a grade 1 reaction as opposed to a grade 4 reaction. And that will help us as we still, there's a lot to be learned yet in this area as we try and hone down more on what's actually happening, what can we measure, what can't we measure.
And you mentioned that the period of time begins really with induction of anesthesia. Is there a certain period of time where it's no longer considered perioperative? Is it once the operation is complete and the patient wakes up, or do we have a better definition of that?
It's not super well defined, but in general, once, the surgery is over and, they've left the OR, pretty much that encompasses the time frame that we're looking at.
hmm as you mentioned, sort of that first patient you saw and the patients I've evaluated, it's almost one of the scariest scenarios imaginable of, somebody experiencing an acute, systemic, potentially life-threatening allergic reaction in the middle of surgery. It's just awful. Do we have any idea regarding the prevalence or how frequently this occurs?
Yeah, fortunately, we do. And again, a lot of this data comes from Europe in particular because they have centralized areas for studying this where there is a pretty well known numerator and denominator. Here in the US, it's much more difficult because how many surgeries were done in the US, how many, perioperative anaphylaxis cases actually occurred. That those numbers are very difficult. But the number that's floated around the most, and I think that's most accurate and easiest to remember, would be 1 in 5,000. That's some recent data. And Dr. Alexi Gonzalez just reported, looking at ICD codes using a whole nationwide inpatient sample database, came up with like 1 in 6,500. So it was very close to that 1 in 5,000. And some of the more recent UK comprehensive studies, point in that 1 to 6,000 range also.
So if we take 6,000 surgeries occurring in the United States or in a large database, we'll have one episode of this. But I'm
Mhm.
sure that there are certain patients or types of surgery or risk factors that would increase that sort of risk of perioperative anaphylaxis. Is that has that been well established that can allow for sort of a heightened state of awareness going into that surgery?
Not I mean, there are some surgeries and underlying processes, particularly cardiovascular and hematologic, that may be slightly more than another type, but those numbers overall aren't hugely different. So we're there isn't just, one type of procedure, really considered more at risk. The main thing that helps predict risk is unfortunately just a previous reaction with a surgery or procedure or known sensitivity to some of the medications or substances that are going to be used in the surgery. But sometimes that gets overlooked. I've seen a number of people now over the years that when I'm getting, the history, they said, "Yeah, I had reactions with my last 4 surgeries before this one." So it is important, as part of a preoperative assessment, when they're looking at diabetes, heart condition, et cetera, and all, to ask, did you have reactions, even if they were mild with previous surgeries?
That leads me to my next question, I guess. So, in your experience, do surgeons and anesthesiologists and other members of the surgical team have a good awareness of perioperative anaphylaxis?
Yeah. Overall, I think the anesthesiologists do.
Mm.
I've been able to work closely with the anesthesiologist here and fortunately had the opportunity to speak at the Postgraduate Assembly of Anesthesiology. It's an annual meeting they have in New York City. And what I learned is anesthesia is very protocolized. If something happens, there's a checklist that they go through. And if there's, things happening that suggest anaphylaxis, they do have a protocol. Boom, boom, boom. Fluids, epinephrine, and what we're trying to get at tryptase level. And fortunately, they've done that here. But my sense is the anesthesiologists do have a pretty good understanding of this and are working at tweaking their protocols, not just for that moment, but also to be helpful for down the road when we're trying to assess what's happening.
So, here's the follow up question, not to put you on the spot. Do allergists have a good awareness of perioperative anaphylaxis?
Overall, I think it could be improved. Again, it's going to be quite variable. There's many, many that have super understanding of this, but there's a lot that just simply do not. And we have seen people referred here where they were told, "Well, there really isn't any way we have to evaluate this," or if you just avoid the neuromuscular blocker or the antibiotic. So I do think more awareness needs to occur in the allergy community. I think it has improved significantly over the last 5 to 7 years, but there's always room for improvement.
And I think that's a great segue into the course that you helped develop. So, can you offer some background as to why the American Academy of Allergy, Asthma, and Immunology developed this new CME course titled, I love this title, Hidden in Plain Sight, a comprehensive approach to perioperative anaphylaxis? Why was this developed?
Well, I was approached by Dr. Teresa Bingaman, who at the time was the chair of the anaphylaxis committee, in the academy, and she was interested in looking at putting together maybe a position paper or guideline on perioperative anaphylaxis. And we worked on that with some other members of the anaphylaxis a committee of the academy, and but what we were putting together really didn't deviate much from what was already out there. There have been a couple of really excellent reviews in Jackie in Practice on this topic, and in addition, the European Academy of Allergy and Immunology has a just a outstanding summary of evaluation and management of perioperative anaphylaxis. And, when we decided, yeah, this isn't quite working out, we thought, well, maybe there's another way we can approach this educationally, because that's really what we want to do is educate allergists on this. So we put forth a proposal to the academy, through the education group to do online course on perioperative anaphylaxis. And fortunately, the proposal was accepted, and then we were able to move forward.
I applaud you for doing that. I couldn't agree more. I think we all sort of get guideline fatigue, and it's sometimes buried in the middle of a thick journal, and it's hard to always pay attention to the minutia and the details and the nuance. Where can members access this curriculum, and how many hours of CME can somebody earn by going through it?
Well, access now especially may be relatively easy because the academy are sending emails out to all members of the academy, outlining that this online course is now available. Um, but if you, like me, delete a lot of emails, if you just go to the Academy site, it is on the website. It is buried just a bit right now. So you just go to the professional education tab, which is right at the top of the the opening line, and then you drop down to CME, and then it's housed under anaphylaxis, urticaria, and angioedema. So it's just a couple quick clicks, and then there you could access the course. It's approved for 2 hours of CME credit, and it's free for Academy members.
Okay, free for Academy members. I like
Mm,
that. And for everybody listening, if you go to our landing page for the podcast, we'll put a link underneath this episode as
mm,
well, so it'll go straight there.
mm.
What can we expect as we take this course? Is it interactive in any way? And if so, what does that look like?
Yeah, so we tried to cover all aspects of perioperative anaphylaxis in a practical but also fun way. As you mentioned, it's pretty easy to get guideline fatigue. So we really wanted this to be interactive. So as you go through, you're going to see multiple places to click, and there's going to be pop-ups that further explain the different processes that are being talked about. And we've broken it down into a number of segments, all of them interactive. For the epidemiology aspect, for example, there's a map of the globe, and then areas where you could just click on different countries and it'll immediately pop up their incidence of perioperative anaphylaxis and the most common cause. Um, and then under causes and evaluation, you get to work through a case where you're asked questions as you're going through the case, but then also shown what are the correct concentrations to use for testing, what should be tested, the value of tryptase, for example. And at different points going through the case, you have to answer the question or it won't let you go forward. So it involves some active learning there. In the communication phase, and this is something I wanted to put a lot of emphasis on, we covered it from all angles because really, for perioperative anaphylaxis to get evaluated, it has to start with the event. And it's very important that the anesthesia and surgery teams let the patient know how important this was and the importance of seeing an allergist to get it further evaluated. So there's a communication piece and template for the surgeon or anesthesiologist to give to the patient. And if we could supply that to the anesthesiologist that we work with, I think that just helps things along for them. And then also a communication piece for the anesthesia to send to us. Let's say, somebody has a perioperative anaphylaxis, they're going to be sending a person your way. There's a template that if they would be willing to fill it out or at least provide the anesthesia record, can make our jobs a lot easier. And it has the pertinent information that we would need. And then also too, and just as important, is after our evaluation, templated letters to send out to the anesthesia team, to the primary care provider, and to the patient themselves, so they can carry that information with them going forward. And it's set up, for the practicing allergist, so they could just download those templates, and then it's just plug in, plug in, plug in, and boom, they have a very nice organized letter that they could send out to people. I've been doing that pretty much exclusively these last couple years, and for the first time in 25 years, I've actually gotten thank you notes or messages from people that received the letter, thanking me for having an organized plan, because part of that too is the plan going forward, what to do with surgeries. And then also, There are 2 videos in it. One is just an interview, very informal with an anesthesiologist getting their sense of what do they think when they're going through a perioperative anaphylaxis event, in the OR, and that was really eye-opening to me because, they're basically diagnosing and treating an urgent event at the same time, and there's so many different things that could be happening there. So it was very interesting to hear their mindset. And then also too, another video where an anesthesiologist and I just walk through an anesthesia record, the medicines that are given, how the timing is listed, how to interpret the vital signs when something's happening, which again, real eye openers as far as I'm concerned, and I think it would be valuable for people that are watching that.
Oh, I completely agree. It sounds like you really thought of all the different aspects as well as unique ways to present the information. As you mentioned, a crucial part of this is just communication with the entire team. So, is this course accessible for non-academy members?
Yes, there is a fee for non-academy members. It's $25, but yeah, as far as I know, it is available.
Oh, I think that's great. Well, let's take a deeper dive into the fascinating topic of perioperative anaphylaxis. You touched upon some of these things, and again, for all of our listeners, please check out the course, especially if you're Academy members. It's free for you. What are some of the symptoms that can occur, and how does the surgical setting make it more challenging to identify them?
Yeah, unfortunately, the surgical setting does present a number of challenges. Really, the first one is we're not getting a history at all. The patient is intubated. They're not able to tell you if they're itchy, if they're lightheaded, if they're having trouble breathing. And then, two, they're completely draped. So if there are skin manifestations, nobody's really able to see those. But what I think really is most challenging is that 50% of the time, the only symptom of perioperative anaphylaxis is cardiovascular collapse.
Mm.
So, and as you could imagine, there's a lot of different things that can cause cardiovascular collapse, but the perioperative anaphylaxis can be one of those without other clues to really hone in on what's happening.
Can you better define cardiovascular collapse for those who may not be familiar with what you mean by that?
Yeah, so there I'm just referring to severe hypotension,
Mm.
basically, a loss of blood pressure.
Okay. And how crucial are vital signs? You mentioned that before as part of the course, but is that a major part of sort of the symptomatology and what's going on in the acute setting?
Yeah, it's really critical. And in the OR, everything is monitored. So they, have the heart rate, they have the blood pressures, they have the mean arterial pressure, and then also too the tidal volumes, the respiratory
Mm.
opposition. So they have a lot of data, so to speak, to go on. But even in that situation, it doesn't always point to just one thing.
Hmm. You sort of alluded to this, but I can only imagine that there's a wide differential diagnosis to consider when any of these symptoms occur in the surgical setting. What are some of the mimickers of anaphylaxis in the perioperative setting?
Yeah, unfortunately there can be a number of mimickers, and I think the way to think about it is first to divide it between non-immunologic and immunologic. Now, in non-immunologic, that's when you think about, go back to your medicine days. A person could have an arrhythmia, they could be having an MI, they could be having a PE, they could be having an air embolism, hemorrhage. All of those things you can look like perioperative anaphylaxis, without skin changes. So that's kind of the one big group, and that's what the anesthesiologist and the surgeon are working on, furiously during one of these events. But then on the the immunologic side, there's also a number of different things that could be happening. We think of, the IgE mediated classic allergic anaphylactic reactions. But in addition, there can be non-IgE mediated allergic reactions or just generalized mast cell release with
Mm.
histamine release. Sometimes too, there's IgG mediated reactions, complement can be involved. And two, if the patient has underlying problems like a mast cell disease or chronic urticaria or angioedema, those could also happen to flare at the time of surgery and cloud the picture.
You mentioned this serum tryptase several times already. Can you
Yeah.
tell us why it's important, what the optimal time frame is in obtaining it in relation to the onset of symptoms, and also what do we do if it's either normal or not obtained at all?
Yeah, boy, if I could have one thing, it would be tryptase with any questionable, perioperative anaphylaxis case, because it's really the only thing that will cause a significant elevation of tryptase, in that event. And, as I mentioned earlier, just severe hypotension, cardiovascular collapse can be the only cause. Or could be the only manifestation of perioperative anaphylaxis. So, when you're assessing the case, and if you have a significantly elevated tryptase at the event, then you know there was something happening from an immunologic standpoint. If it's the problem is though, if it's normal, it doesn't rule that out.
Hmm.
But I've been amazed at the number of cases that I've seen where the person had absolutely no allergy history, and their event was just severe hypotension without anything else, and without having that elevated tryptase, it just made you wonder, well, what was there something else? Clearly there must have been something else. But that tryptase is huge. Again, very, very helpful when it's elevated. If it's not, though, it does not rule out a perioperative anaphylaxis event. So keep that in mind. As far as timing of it, ideally, everybody talks about 30 minutes to 2 hours is, into the event is the peak. But unless you have it as part of the protocol for the anesthesiologist, oftentimes they will not get it in that time frame because, they're busy with a whole lot of things going on there. But even if it's gotten 6 hours later, and I've had instances where it's still been elevated 12, even 20 hours
Mm.
afterwards before it subsequently normalizes, I would say, if there's an opportunity to get a tryptase, get it. Ideally, though, it would be somewhere in that 30-minute to 2-hour range.
Do you routinely recommend repeating a tryptase at baseline, whether or not it was elevated? So, and in other conditions, there's the quote unquote normal range, and then comparisons when they're acutely ill and symptomatic, and when they're at baseline. So, is that same rules apply with this, or not so much?
Now, I would say the same rules apply because when you look overall at the best sensitivities and specificities with tryptase, it is using the anaphylaxis equation, the 1.2 times the tryptase plus 2. So even if it's normal, I do think it's important to get a baseline if there is suspicion of a perioperative hypersensitivity event. And then if it's elevated, it's really important to get a baseline because if it's still elevated days or weeks later, then you may be dealing with an underlying mast cell disease.
Mm-hmm. Absolutely. Well, what treatment should occur in the acute setting when they're in the operating room, or right before they're about to start the surgery? What should the treatment be, and then can the surgery still proceed?
Well, the treatment is very similar to how you would typically treat anaphylaxis. The advantage actually of treating it in the operating room is that there are lines in, they're being monitored, and the anesthesiologist will use IV epinephrine. So in this situation, they oftentimes will do boluses of it, but also, if needed, could start a continuous drip. So in the OR, instead of doing the IM epinephrine, which we're used to prescribing and thinking about when we think about outpatient anaphylaxis, it's a little bit different in the OR, and they're able then too to control the rate. With an IM injection in the OR, you really don't know for sure how the absorption's going to be, and also it's just harder to regulate as opposed to really by the minute regulation of the epinephrine IV wise. Also, major fluid resuscitation is huge, and that's something in anesthesia circles that they talk about sometimes does not get done in those settings. And then they're also, exploring different novel treatments for perioperative anaphylaxis in the OR setting. But the basics are still the epinephrine and fluids.
Mhm. Are there any circumstances when the surgery can still proceed after they get treated and they return to they're stabilized?
Yeah, it's extremely variable. So one of the first questions is, where are you in the surgery? Are you almost done? Has the first incision not even been done yet? And then the second really is that severity. When we were talking about the modified scale, 1 to 4, if it's a 3 or 4, then usually, unless they're really got things under control quickly, they they won't proceed going forward. But if it's lower grade, well controlled, then surgery sometimes can be completed. It's hard to put a percentage on it because the severities are all across the board in this, and
Mhm.
then also where you are time wise. So it is very individualized.
Absolutely. I don't know too many allergists. You may have a different cohort of friends that you hang out with that are, hanging out in the operating room or that are necessarily immediately available should a perioperative anaphylaxis occur. So we're often meeting these patients after the fact. As such, what type of standardized history should we all obtain once we're consulted on these patients?
Yeah, once we're consulted, really the key thing is having access to the anesthesia record. And I want to emphasize that's completely different than the surgical note. The surgical note describes what happens during the surgery, but typically it says nothing about the anesthesia used, the timing of the medicines, and then even if an event occurs, the details of the event. So having the anesthesia record is really critical, and sometimes you can, request that. As part of the template that I mentioned earlier in the communication piece, we ask for that from the anesthesiologist. But Dave, one thing I really want to emphasize in this podcast today is it's important to talk to the anesthesia team. They're more than happy to talk to you about the case because they know this patient may be coming back again someday and they don't want to go through this same event either. So every situation I've had where I've got a hold of the anesthesia team and we kind of walk through what actually happened there in the OR, they've always been happy to discuss it and provided extra information that you can't glean from the records, and the patient can't tell you, they were out. So communication there to walk through the case, get their sense of what was happening is really critical. In addition to looking at that anesthesia record.
Um, I couldn't agree more about the importance of communication. So you mentioned going through the complete record. Just based upon our understanding of perioperative anaphylaxis, are some medications more likely to be the cause? And if so, can we just assume which medication caused the suspected anaphylaxis based upon the history alone?
Yeah, unfortunately, we can't really just base it on the history alone because there's so much happening in a very short time frame. The average person is getting about 7 or 8 medicines during anesthesia, and the vast majority of them are given within, a 5 to 15-minute period of time. So history-wise, they may say, "Well, while I was pushing this happened," but they received 3 other medicines 10 minutes ago, So, I wish that we could count just on the history, but it's not a safe way, to go with this. The way we look at it is any medicine that was given prior to the event is a possible cause. And there definitely is a pecking order to this. Here in the US, number one cause is the antibiotic given, usually cefazolin because that's the one most commonly used. Second is the neuromuscular blocker medicines, and those are, the severe muscle relaxants like your vecuronium, rocuronium, succinylcholine. Third, actually, is an antiseptic, chlorhexidine. Something that at least I never initially thought much about till, started reading about this and talking with the people that were working with it. And then latex is still on the list. But again, anything given prior to the event is a possibility. And two, there can be other things depending on the type of surgery. Sometimes different fibrin products are used or glues. And oftentimes you could only get that information if you talk with the people that were in the room.
I can only imagine that if one of these patients, shows up on the schedule, whether it's a community-based allergist or somebody in the academic setting, and you're in the middle of a busy day seeing other patients, that it's going to put a bit of a kink in your schedule. So, are there ways that we can identify these patients ahead of time and schedule them accordingly? Or, what if they do just happen to pop on our schedule in the middle of a busy day? How best can we serve them at that moment?
Yeah, that's a tough problem, and again, every office is gonna be set up, differently. If, people are able to look and see the reason for appointment, perioperative anaphylaxis, then you could kind of plan ahead at least a little bit, for that. Again, how far out is that going to be? It's gonna be very variable depending on the office. But if the person does just show up, you're not gonna be able to do the complete evaluation that day, but you can set the stage for the patient. And I think half the battle with this too is being able to tell the patient, you know, this event occurred. We do have a way of assessing what happened there to try and determine the actual culprit so that future surgeries could be performed safely. And again, I've had a number of people come through that were told, "Oh, there's nothing that we can do for this." And just, initially telling them, "Yes, there is, and we do have a standard way of approaching this," that just seemed to, in of itself, give them a sense of relief and also motivation then to follow through on the evaluation. Again, you won't be able to do it all that day, but and it is a bit of a time sink sometimes to set things up for this, because you have to get the anesthesia record, hopefully have a chance to even review it with the anesthesiologist, and then get the medications needed, for the testing.
Yeah, so walk us through that. What does testing look like when we have this long list of suspected medications? Are there standardized protocols, and is it safe to do this testing in the outpatient setting?
Yeah, the primary testing we do for this is skin testing, and that is considered safe to do in our office, in the outpatient setting. And that list of, 6 or 7 is usually divided into the neuromuscular blockers they received, the sedative medicines they also received with it, the antibiotic, and I feel everybody that has a perioperative anaphylaxis event should also have chlorhexidine and latex testing done no matter what. No questions asked, we're going to do those 2 tests in addition, to all the medicines that they received. A problem can occur though with getting a hold of these medicines because they're, neuromuscular blockers, they're the sedatives, the fentanyls, the opioids, those type of things. We work through the hospital pharmacy to get those, and then, we dilute those down to figure out, well, what concentrations do you use for the testing? There are guidelines that to follow for that make it very straightforward. The primary guidelines come from the European Academy of Allergy and Immunology, and they published their position paper on it in, I believe it was 2019. And most recently, in our academy and college, the anaphylaxis update includes a section on perioperative anaphylaxis, which also provides the highest non-irritating concentrations for these medications that are used during anesthesia, surgery, and procedures.
So, what about somebody who it doesn't have access to a hospital pharmacy per se? They're out in the community and they're trying to do the best to help these patients. I assume you can't just write a prescription for fentanyl and have them go to the local pharmacy and bring it back to the office. Are there resources available to help with procuring these medications?
Yeah, I'll be honest, I don't have a good understanding of that, and in
Mhm.
general, though, in talking, though, with, some of the community allergists, I think it would be best if they just sent the patient to a center that is able to do that without having to go through so many hoops, because, it isn't just one medicine, it's going to be a number of them, and, to try and do that, completely by yourself with no mechanism, I think would be extremely difficult.
Yeah, that makes perfect sense. What about testing? Is it always straightforward where you get a positive result only for the actual cause and everything else is negative?
No, unfortunately, testing isn't always 100% straightforward. And firstly, I mean, if you just look at, all of the different studies, in particular, even from France and the UK, where they have centralized areas to do this, they find a culprit approximately 60% of the time, meaning 40% of the time, nothing is clearly identified. I would say in general, false positives with the current standards for testing tend to be unlikely unless you're dealing with opioids, where sometimes you can see false positives. But the remainder, false positive rate in general seems to be very good. The skin tests, again, kind of guide you. I would say in our experience, the majority where we have found a culprit, it is one that is positive, and the others are indeed negative. In the literature, they do say up to 8 to 9% of the time there can be two things that have contributed to the perioperative anaphylaxis event.
So let's say you have a good positive and you think you found the culprit and you have negative testing for the other medications that were received just prior to the event onset. Can you just simply receive all those medications again without any precautions, or how is that approached?
Yeah, it is felt that the other medicines, should be fine. The one that was positive, you would wanna double check and see, depending on what it was. For example, if it's a neuromuscular blocker, there is a chance that they could be cross-reactive to other neuromuscular blockers. That's where it really comes in handy too to talk to the anesthesiologist and ask them, which one would you want to use with a subsequent surgery? So you could test to a few others to find one that is negative that then they could use with an upcoming surgery.
Okay. And then what happens for those that you do find that positive one and you're pretty sure that you have the culprit there? You mentioned about some standardized templates and letters, but how do you close the loop with the entire surgical team and everybody else involved in that patient's care?
Well, what we've been doing is sending a letter to the anesthesiologist, to the surgeon, to the primary care provider, and to the patient. And then making sure that our electronic medical record is updated with what they were sensitive to. And in those letters, it includes, what was positive, but also what was negative on the testing, and then clear recommendations for an upcoming surgery.
Okay. We sort of alluded to this earlier, but can you tell us a little bit more about other underlying conditions that we should keep in mind that may make somebody more prone to experience perioperative anaphylaxis, whether it's a true immunologic response or not? And what are some of the red flags that should prompt additional evaluation?
Yeah, the main things that could really manifest or interfere are mast cell diseases of any sort, whether it's underlying mastocytosis, mast cell activation syndrome, um, underlying urticarian angioedema, uh, 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 hereditary angioedema. I would say those are probably the main ones that could get exacerbated or contribute to an event.
Okay. You have a very strong personal interest, obviously, in perioperative anaphylaxis. You're one of the world's leading experts in regards to your level of knowledge and understanding. But for those listening, or for our colleagues, what's your call to arms to get everybody to become interested in learning more?
I think the key is awareness. And, as our recent anaphylaxis parameter pointed out, the people that have had perioperative anaphylaxis and then had an allergy evaluation have done extremely well with subsequent surgeries. Less than 2% of people will have some type of reaction with a subsequent surgery. So going through these paces works. And we're dealing with, a kind of a life and death situation here. And to have the opportunity to be able to help a patient in this manner, I think is just huge. And it's such an important part of our practice.
You've provided a wealth of knowledge for us. I encourage all of our listeners to take the free online course to learn even more. We covered a lot. Did we miss anything?
No, but I do want to say thank you to a number of people that helped make this possible, but and also too that have been really active in the perioperative anaphylaxis venue. I feel a little bit like this might be an Academy Awards type list, but
Hmm.
these people really need to be recognized. So, in particular, Dr. Teresa Bingaman, who came up with you know really interest in this and helped set things up with the academy, and then also helped with these modules. Dr. Alexi Gonzalez, who helped with the modules and also has been involved with a lot of research in perioperative anaphylaxis, and then two other collaborators with these modules, Dr. Sarah Anvari and Dr. Anil Nanda. And perhaps most importantly, I want to thank Erin Levenhagen. She is the e-learning program manager at the academy, and she took all of our information and put it together in very creative, interactive, and interesting ways. When we started this project, I had no idea how this was going to turn out, and it exceeded my wildest dreams. And a lot of that is due to Aaron to really make this a fun, interactive way of learning and hopefully learning a lot about perioperative anaphylaxis. Also, too, the anesthesiology department at Mayo has been super, especially Dave Martin, who did the videos with me. But he's fortunately a very good friend also, and really helped show me the ropes as far as anesthesiology and allergy go. And last but certainly not least, the ISPAR group. This is the International Suspected Perioperative Allergic Reaction Group. It's an international group that consists of both allergists and anesthesiologists with interest in perioperative anaphylaxis from a practice, research, and education standpoint. I feel like I've had the opportunity in that group to work with my heroes, people like Lena Heisey Garvey, Michelle Mertes. These were the people that put together a lot of the initial data with this and continue to contribute in a huge way to perioperative anaphylaxis today. We do have a website for that ISPAR group. It's www.perioperative.allergy.com. It's open to anybody, and there's a lot of good information there for people that have an interest.
Well, Dr. Volcheck, your passion and enthusiasm are infectious. I can't wait to
Mhm,
take the course, and I hope
mhm.
everybody else does as well. Thank you so much for taking time out of your schedule to join us today.
No, thank you, Dave. I really appreciate this.
We hope you enjoyed listening to today's episode. Please visit www.aaai.org for show notes and links to the course that we talked about today from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Amazon, iHeartRadio, or Spotify so you can receive new episodes in the future. Thank you again for listening.